Accident and Injury Prevention, Introduction to Nursing Concepts. This is Martha Olson. As we look at our principles of safety, we will be talking about many of the factors that affect safety, some of the risk factors in a specific healthcare agency, and then some of the ergonomic principles that follow with that. Factors that affect safety include our vulnerable populations: infants, children, older adults, the ill, the disabled, people that are illiterate and very poor. The threats to safety include many things such as carbon monoxide poisoning, food poisoning, that we talked about in nutrition class, fires, pathogen transmission in the infection control unit. So we need to maintain that basic human need of oxygen, nutrition, temperature, humidity. With carbon monoxide, remember, it's a colorless, odorless, poisonous gas that's produced. It binds very strongly with hemoglobin, preventing the formation of oxyhemoglobin, reducing the supply of oxygen to the tissues. Suicide or accidental deaths from sitting in a running car in the garage from carbon monoxide poisoning is sometimes seen, especially in the elderly. They're debilitated, they have no family help, they have a lot of health care issues, and it just seems like one way out. With food poisoning, hepatitis A is spread by fecal contamination of food and water and milk. 2-week period before the onset of jaundice is your most contagious time. As we look at the world and, environmental, we think of a clean water supply. With temperature, that hypothermia and heat exhaustion also falls into our safety and accident unit. We know that that is very high risk for the elderly, people that are drunk. Many people die outside because they can't get their keys in the door in the winter when they're drunk and their friends have dropped them off, and they find them in the morning frozen. The homeless, those with cardiovascular conditions, are very susceptible to temperature extremes. And then humidity. We live in Iowa, so I'm not sure what more I need to say. Increasing the environmental humidity can have therapeutic events for some patients, but humidity then can also cause problems for other patients. We see more asthma and respiratory conditions in the summer with humidity here in Iowa. When we look at risks in the healthcare agency, we know medication errors are going to be a huge part of what's going on. Infections after surgery, that nosocomial or hospital-acquired infection. We've done the pressure ulcers. That failure to diagnose and treat in time is a huge one that they are looking for in that evidence into new practice. Are you identifying and treating in time some of those problems that are identified? The MSDS sheets for any chemical in a hospital. Even here at the college, we have those MSDS sheets for any chemical property, so that we know if somebody gets it in their eyes or swallows it or has a spill, gets it on their skin, how we would treat that. Our incident and accident reports need to be made out in a timely manner. They help us to find ways to prevent that in the future. They are not meant to be punitive, but they are looked at. And remember, your incident report is not documented in the medical record. When we look at some of our ergonomic principles, keeping our backs from getting injured is a very important part of what we do, and keeping our patients safe. When we use a Hoyer lift, a lot of your patients feel much more safe and secure instead of having 3 nurses come in and drag them around by their limbs to get them up to the chair. Things that we think of, mopped floors that are wet versus carpeting. Carpeting is very hard to clean. If you have somebody that urinates, vomits, blood, anything on carpeting, it can be very hard to keep clean, and that's why many of your hospitals have floors that are mopped every day. But then do we take a risk of falling from those mopped floors? Putting the bed in high position so that as a nurse we don't injure our back, but remembering then to put that back into low position before we leave that patient. The easy stand is used in the hospital and also in long-term care. It assists the patient to a standing position. You can then take them down to the toilet, to the chair, or to the commode as needed. When we look at assessment of the patient, you can see the correct principles of using the gait belt. That picture with the lifting, you see the back is straight. That caregiver is using the strongest legs in the thigh and bent at the knee to have good position to help that. When we look at the beautiful pink bathroom on the right, we notice that there's a lot of scatter rugs, and those would be a hazard for falling, especially at night with the elderly. So as home health nurses, home care nurses, we would be assessing that environment and helping them to make changes that would make their home environment much more safe. We need to educate on admission, during hospitalization, and discharge about different safety things. On admission, we introduce them to the bathroom, to the call light, to the side rails, what their ambulatory status is. You may get up to the bathroom by yourself. No, you always need to call and have help. Because we are accountable if a patient falls, we have to maintain that accountability. We have to anticipate any necessary information, analyze that data, and then make decisions regarding client care and safety. Even though they're young and healthy and they just had surgery, that orthostatic hypotension, that blood loss, that reaction to the anesthesia might cause a patient that before surgery is very mobile and very safe. They would not be safe going to the bathroom alone then post-surgically. As we look at our nursing diagnosis, our two-part risk for injury related to impaired mobility, some of the nursing interventions are listed in the book on some of the practice exercises. We can also look at risk for injury related to some of the barriers in a home care environment. So even our home care nurses have to anticipate risk for injury. Our planning, where we put the equipment. The IV pole usually goes on the side that the IV is on, but sometimes that makes it very difficult for the patient that gets out of bed on the other side, and it takes a lot more time. What medications are they on? Are they on medications that can cause dizziness and potential falls? Obstacles like a wet floor, throw rugs, any clutter. We try to keep the rooms as free from clutter as we can. How is their eyesight? How is their strength and balance? Those are all things for nursing considerations to prevent falls. Getting to the bathroom, security, things like no smoking in all hospitals because we have oxygen and that would be a fire hazard. Lead in the water for the home health or public health nurse. All of those are nursing considerations that we need to make to keep the public safe. When we implement those preventative measures, these are talked about thinking and anticipating ahead. What is their fall risk? Use of restraints and devices. Spend a lot of time in your powder and peri reading that because there are quite a bit of implications and implementation processes that relate to the use of restraints. And then how do we prevent a patient from eloping or leaving our facility? There is a lifeline that patients at home can use. In the hospital, we do have bed alarms. We typically pin them to the back of the gown so the patient doesn't take them off and then get up and go to the bathroom on their own anyway. When we look at other preventative measures for the infant, we look at immunization and car seats. For the preschooler, safety at school. The preschooler is usually big enough to climb up on the cupboard, so are the pills in a place where they can't get to them and eat too many Flintstones vitamins because they think they taste good. Preschoolers are learning to walk and run, and so there's a lot of safety that goes along with learning to ride a bike and all of those physical things that they do. With adolescents, we think of suicide and pregnancy, also driving, motor vehicle accidents. With our adults, stress, nutrition, childbearing become kind of the focus of different things that we need to think about. And then with our older adults, choking because of dysphagia, safety, our risk for falls. When we look at the use of a gait belt, the one on the left is an older one. Remember that we put it on so that the first part that goes in is with the jagged teeth to help secure it in place. They need to be used at all times. The gait belt on the right has the handles. It usually clicks into place, so once you have it set for the size of the person's abdomen, it's quicker to get on. If you have a patient that is very large, we have had to order some of the bigger size gait belts, but if you're in a facility where you don't have a bigger one, what we typically do is take two of the gait belts from the left side and hook them together to go around somebody bigger. If a person is pregnant, has an abdominal wound or a new colostomy on the lower abdomen, you can put it up higher under the armpits above the breast area to secure a gait belt for them. Factors in the hospital that predispose a patient to falling. The Potter and Perry book lists many of them. Being in a new place, having an acute illness, surgery. What is their mobility status? Are they weaker? Do they, now have something, on their foot like a cast? What medications are we giving them, especially our pain medications? Treatments. Do they have a catheter or a tube that we have to worry about? I can't tell you how many times patients have about tripped and fallen over their IV pole trying to get into the bathroom. As we look at restraints, we know that it is not a solution, but it's rather just kind of a temporary way to help us figure out what we need to do to keep a person safe. The picture here with the vest restraint, those are no longer used. That's because these patients will wiggle and squirm. It gets up around their neck and it becomes a very high risk for a choking hazard. So we do not use vest restraints any longer. Neither do we use gait restraints or the ones just around the abdomen. As we look at restraints and safety, we know that they are associated with complications. A restraint-free environment is our goal. There's a lot of things we can do that help us to keep a patient safe without using a restraint. We know we have to have a physician's order. It has to be renewed every 24 hours. But the policy of every facility might be a little different, and we have to follow it very explicitly to make sure that we are in compliance. There is such a thing as a chemical restraint, and that would be a medication that alters the behavior or cognition of a patient. So we can't drug them up just to keep them in bed. Yeah, let's give them sleeping pills and a pain pill, and I bet they'll sleep for 4 hours and not be climbing out of bed. We can't do that. In the physical restraint, we also have to remember that a physical restraint is not something that the doctor orders, like an orthopedic device, like traction, a surgical dressing, protective helmets if somebody has seizure disorders. Those are not considered a restraint. With immobilization, as a result of using restraints, we know that the complications are there. Pressure ulcers to those bony prominences, constipation, incontinence, restriction of circulation. If it gets too tight or they wiggle or get it twisted, it's going to be cutting off circulation. Loss of self-esteem and humiliation. Agitation. Sometimes when you restrain a patient, they actually get more agitated, more restless, and more fidgety than if you would not use a restraint. So again, know your policy. Make sure if you have to use it that it does not interfere with your IV. Make sure you pad skin and bony prominences. Attach straps to the bed frame, not to the side rail. And then use that quick release tie, as we'll demonstrate for you. And reassess often that the patient is tolerating it well. As we look at this picture, this is a chair. On the other side is a garbage can. One of the things you cannot do is to put the foot up on this chair in the hospital and then put the garbage can underneath to prop or support that foot up. That is considered a restraint because the patient cannot use their feet to push the chair down and get out. It's done sometimes innocently, not as a restraint, but because the person is very heavy and the foot will not stay up because of the patient's weight, but that cannot be done that way. This chair, the black one, can be done that way. The patient can push that down and get themselves out of the chair, so that that is not considered a restraint. And each one of the chairs has a lock, and so you would want to make sure before you transfer or pivot a patient into a chair that you have them the wheels locked so that that doesn't become a source of injury or an accident. Other interventions we use to avoid restraints. I have seen times where we have put a patient in this chair. If you put the tray over the front of them, that is considered a restraint if you're only putting the tray in front of them to restrain them in that chair. If they have something on the tray like a drink, an activity, a book to read, then it is not considered a restraint. But again, every facility kind of has their own policies and rules, so make sure you're very clear before you work in a facility as to what is tolerated and what is not. When we look at other interventions to avoid restraint, there's a good table in the book that talks about that. Bed alarms, a sitter, just getting another nursing assistant to come in and sit in the room with that person is sometimes useful. Eliminate as many tubes as you can, have them familiar, have a clock, pictures, calendars to help familiarize them with the environment, and then ambulate them as frequently as possible. This is the end of our first part.